Picture the letter. You have probably seen one, or you're going to. It arrives in the mail, or it shows up in your patient portal with a subject line that says something like, "Prior authorization decision." And somewhere near the top, there is a single word that changes your afternoon. Denied. Your doctor ordered the treatment. Your doctor examined you in person, reviewed your history, weighed your options, and made a clinical judgment. The kind of judgment that medical school and residency and years of practice are designed to produce. And then something reviewed that judgment and decided no. In most cases, that something took less time to decide than it took you to open the envelope. What I want to show you today is what actually made that decision. Not who. What? Because the entity reviewing your doctor's medical judgment is not a physician. In a growing number of America's largest health insurance companies, it is not even a person. It is a piece of software running a financial calculation that has nothing to do with whether the treatment is medically necessary, and everything to do with whether the company believes you will fight back. This is not a story about one bad insurer or one controversial claim. It is a story about a system that was built deliberately, documented in congressional testimony, and operating right now across hundreds of millions of Americans' health coverage. And it is designed around a single documented fact about human behavior that the insurance industry is counting on you to prove true again. Let me give you the number that makes this whole system work, because without this number, the rest of the story doesn't make sense. When a health insurer denies a prior authorization request, the patient or physician can appeal. The appeal process exists. It is real. And in the cases that reach an independent reviewer on appeal, somewhere between 60 and 80% of those denials get overturned, according to CMS data tracking Medicare Advantage appeals outcomes. Read that again slowly. The majority of prior authorization denials that are actually challenged are found to be wrong. If the majority of appealed denials are reversed, the obvious question is, why do the denials keep happening at all? The answer is that only about 11% of denied prior authorization requests are ever appealed. Of the nearly 250 million prior authorization requests submitted to U.S. health insurers every year, a number that has grown by more than 23% over the past decade, according to the American Medical Association, roughly 6% are denied. Of those denied, 89% are never challenged. The treatment is delayed, abandoned, or quietly paid for, out of pocket by the patient who assumes the system must be right because the system said so. This is not a bug in the prior authorization system. This is the prior authorization system. The denial does not need to be correct. It only needs to be unchallenged. And the people who built the AI making those denials know the appeal rate almost to the decimal point, because the 11% who do fight back is a number that has been studied, modeled, and built into the financial architecture the same way a retailer builds return rates into their pricing. The denial letter was never a medical judgment. It was a bet that you would not open the envelope and start fighting. To understand how the AI fits into this, you need to understand what prior authorization actually is and why it exists on paper versus why it exists in practice. Prior authorization is the process by which a health insurer requires a physician to get advance approval before a patient can receive a specific treatment, medication, or procedure. The stated purpose is clinical appropriateness, ensuring the right care reaches the right patients and preventing unnecessary procedures. That is the brochure version. The operational reality is different. Prior authorization is the mechanism through which insurers insert a friction layer between your doctor's judgment and your access to care. Every step that requires action from a physician or a patient is a step that some percentage of physicians and patients will not complete. Every additional form is a filter. Every deadline is a trap. Every denial written in medical and billing code that a patient cannot parse is a calculated bet on human inertia. Physicians were already completing an estimated 45 prior authorization requests per week on average before AI entered the picture, according to the AMA's 2023 Physician Practice Benchmark Survey. Their staff were spending an average of 15 hours per week managing the prior authorization process, not treating patients, managing paperwork on behalf of insurance companies to justify care the doctor had already determined was necessary. Then the AI arrived and the scale changed completely. Meet a woman I will call Sandra. She is 67 years old, a retired school administrator living outside Columbus, Ohio. In the fall of 2022, Sandra had a hip replacement. The surgery went well. Her orthopedic surgeon and the hospital's discharge team determined she needed a course of inpatient rehabilitation before she would be safe to return home. The kind of post-acute care that allows an elderly patient to rebuild strength, learn to move safely, and avoid the falls and rehospitalizations that cost everyone more in the long run. Sandra's physician submitted the prior authorization request for inpatient rehabilitation to her Medicare Advantage insurer. The request came back denied within hours. The insurer's determination was that Sandra's condition did not meet medical necessity criteria for continued inpatient care. Her physician appealed. The appeal was upheld on the insurer's internal review. Her physician requested an external independent review. The external reviewer, a physician with no financial relationship to the insurer, overturned the denial. Sandra received her rehabilitation. It took 3 weeks, 3 rounds of paperwork, 2 physicians' working hours, and her daughter taking time off work to manage the process. Sandra is not unusual. Sandra is documented. The congressional investigation that examined this exact pattern, elderly post-acute patients denied rehabilitation following hospitalization, in numbers that could not be explained by individual clinical judgment, found Sandra's insurer at the center of it. Here is how the AI denial system works in practice, using United Health Group as the primary example, because they are the largest private health insurer in the United States, because their algorithm has been documented in formal congressional records, and because the numbers are specific enough to make the mechanism impossible to dismiss as coincidence. United Health Group developed and deployed an algorithm called NH-Predict, built by a subsidiary acquired in 2020 called Navimedix. The NH-Predict system was designed to review prior authorization requests for post-acute care, the medical services patients receive after hospitalization, in inpatient rehabilitation facilities and skilled nursing homes, and to generate automated recommendations at a speed and scale no human reviewer could approach. The algorithm works by analyzing historical claims data, patient diagnosis codes, procedure codes, and a proprietary database of past case outcomes. It produces a predicted length of stay, the number of days the system calculates a patient in a given condition should require inpatient care before they are medically ready for discharge to home. When a physician requests authorization for care that extends beyond NH-Predict's predicted window, the system flags the case for denial or generates an automatic determination without individual clinical review of that specific patient. When Sandra's physician submitted her prior authorization request, here is what that process looked like inside the system that received it, in the exact sequence the algorithm actually runs. The request arrives as a structured electronic submission built around 3 primary data elements: Sandra's diagnosis, codes in ICD-10 format, the standardized billing language that translates her hip replacement and her post-surgical condition into numerical identifiers, the procedure codes describing the rehabilitation services her physician is requesting, and her member identifier, which links the new request to her complete claims history inside United Health's database, going back to the beginning of her coverage. NH-Predict does not read a chart. It reads codes. The moment Sandra's request enters the system, the algorithm retrieves every prior claim associated with her member identifier, every hospitalization, every prior authorization, every prescription, every outpatient visit in the database, and uses that history to build a statistical profile. Not a clinical profile, a statistical one. At this stage of the process, Sandra is not a person recovering from surgery in a rehabilitation bed. She is a pattern of codes that the system has seen variations of millions of times before. The algorithm cross-references that pattern against its training dataset, a proprietary archive of historical cases, each tagged with their diagnostic codes, their approved length of stay, and their eventual outcome. NH-Predict locates the cases most statistically similar to Sandra's code profile. It calculates the distribution of approved stays across those historical matches and produces a predicted length of stay, the number of days the system projects a patient with Sandra's code pattern should require before being ready for discharge. Sandra's physician requested 7 days of inpatient rehabilitation. The algorithm's predicted length of stay for her diagnostic category was 3.1 days. The gap between 7 and 3.1 triggered the denial flag automatically. No one reviewed Sandra's actual chart at this step. No one contacted her physician to ask about her balance assessment, her home environment, her fall risk score, or the clinical factors that had led her surgical team to recommend inpatient rather than outpatient rehabilitation. The delta between the requested days and the algorithm's predicted days was sufficient input to generate the denial recommendation. Sandra's individual clinical reality was not an input the system was designed to receive. What follows the flag is the step the system is most careful not to make visible. In documented workflows, a claims reviewer receives the algorithmic output on a decision screen. Their role at that step is not to conduct an independent clinical review of Sandra's case. Their role is to confirm the algorithmic determination and provide the human signature that the denial letter legally requires. The 1.2-second review times documented in the ProPublica investigation of Cigna's prior authorization workflow are this signature step. The decision was made before the reviewer's screen loaded. The human is the receipt, not the reviewer. Sandra's denial letter was produced automatically. The language cited a specific medical necessity criteria code, the kind of clinical-sounding determination that implies a physician evaluated this specific patient against this specific clinical standard. That language is templated across thousands of cases, carrying the same denial code. The specificity is procedural, not clinical. It is designed to sound like an individual medical judgment, because anything less specific would not survive the legal scrutiny that follows when a patient does appeal. According to a 2023 investigation by Stat News and reporting that informed subsequent Senate inquiry, NH-Predict was documented approving an average of 0.9 days of post-acute care for certain patient diagnostic categories before triggering a denial recommendation, regardless of the individual patient's actual presentation, comorbidities, or clinical trajectory on the day the request was made. The algorithm was trained on population averages. It was being applied to individuals whose situations deviated from those averages in ways the algorithm could not see and was not designed to evaluate. Physicians who appealed NH-Predict denials and reached a human reviewer described patients who were medically fragile, fall risks, and unequivocally not ready for discharge. A majority of those peer-reviewed appeals were upheld. The algorithm was wrong about those patients. It was wrong in a consistent direction: shorter approved stays, faster denials, lower payout. And because the appeal rate was low, most of the patients who were wrong denied never had that determination reversed. They were discharged on the algorithm's timeline, not their doctor's timeline. And what happened to some of them afterward is documented in hospital readmission records that nobody inside the insurance company is required to reconcile with the prior authorization decision that preceded them. A hospitalist I will call Dr. Reyes has been practicing internal medicine for 14 years. She works at a regional medical center and spends, by her own calculation, somewhere between 2 and 3 hours of every working day on prior authorization requests for patients she has already examined in person. Not 2 to 3 hours a week, 2 to 3 hours of every working day. Her practice administrator, whose full-time job is managing prior authorization submissions for the physicians in the building, estimates her own time at 35 hours a week on the same process. None of those hours are reimbursed by any insurer. When Dr. Reyes submitted the prior authorization for a patient like Sandra, she had already spent nearly an hour building the submission in the format the insurer's portal required. The surgical notes, the balance assessment scores, the fall risk evaluation, the specific clinical rationale for inpatient rather than outpatient rehabilitation, the documentation of why the home environment was inadequate for safe discharge at that point in the patient's recovery. She submitted before noon. The denial arrived before 3 o'clock the same afternoon. That turnaround is the detail that stopped her the first time she saw it. 3 hours from submission to denial on a case involving a post-surgical patient whose chart contained weeks of clinical documentation. She had spent an hour building the case for a reviewer who would need time to read it. The system had rendered a verdict in a fraction of that time. "There's no physician on the other end who read what I wrote," she told me. "There can't be. There isn't enough time in 3 hours to review my documentation and make a genuine clinical determination for every case submitted that morning. What reviewed my clinical judgment was something that had never seen this patient, never examined her, never watched her try to walk down a hallway. It looked at her codes, and it generated an output. She filed for a peer-to-peer review, the option that allows a physician to speak directly with a clinical reviewer at the insurer. These calls are scheduled, not immediate. They require a documentation submission that the physician has already prepared in full before the call is granted. They require that the physician carve time out of a schedule already running 2 to 3 hours per day on prior authorization paperwork for other patients. The scheduling window is typically 3 to 5 business days out. Dr. Reyes got the peer-to-peer call. The reviewer on the other end was a registered nurse, not a physician. The conversation lasted 11 minutes. The denial was upheld on internal review. She escalated to physician-to-physician review, the next tier. That call required another documentation submission and was scheduled 4 business days out from the request. By then, the patient had been discharged from the hospital, placed in a care setting the clinical team had assessed as unsafe because the hospital could not hold a bed through the full appeals timeline. The patient fell on the 3rd day at home and was readmitted through the emergency department. Dr. Reyes eventually won the appeal. The rehabilitation was ultimately approved. The coverage the patient was entitled to by the clinical judgment of the physician who had examined her was confirmed after the patient had experienced the exact outcome the inpatient rehabilitation was prescribed to prevent. The readmission cost, by Dr. Reyes's estimate from the billing records, substantially exceeded the full cost of the inpatient rehabilitation stay that had been denied. United Health paid for the readmission. It paid for the emergency care. It paid for the second course of treatment in a higher acuity setting. The prior authorization denial had not reduced the system's cost. It had transferred that cost forward in time to a more expensive event, with worse outcomes for the patient, and no accountability mechanism in the insurer's process connecting the initial denial to what happened after it. None of that outcome is captured in United Health's prior authorization performance data. The denial was eventually overturned. The readmission is recorded as a separate claim. The causal link between them is invisible in the company's reporting. and the company is not required to reconstruct it. This is the sentence that matters. NH Predict was not making medical decisions. It was generating financial outcomes at algorithmic speed. Let me put the financial architecture in front of you, because this is where the design stops being deniable. United Health Group reported net earnings of $22.4 billion in 2023, according to their SEC annual filing. Their insurance division, United Healthcare, covers more than 49 million Americans. The company discusses prior authorization outcomes on quarterly earnings, calls under a metric called the medical loss ratio, the percentage of premium revenue the company pays out in claims versus retains as profit. The lower the medical loss ratio, the higher the profit margin. On United Health's Q3 2023 earnings call, publicly archived through the SEC's Edgar system, Chief Financial Officer John Rex described improvements in what he called care pattern efficiency as a contributing factor to the quarter's results. Care pattern efficiency. That phrase does not appear in any medical textbook. It appears in investor relations language to describe the financial outcome of managing which care gets authorized and which does not. The efficient care pattern in this framing is the one that costs the insurer less. The care that does not get approved is the efficiency. The Affordable Care Act established a minimum medical loss ratio of 85% for Medicare Advantage plans, meaning for every dollar collected in premiums, at least 85 cents must be spent on care. The 15 cents retained covers administration and profit. Prior authorization is one of the primary operational tools through which the care spending side of that ratio is managed downward toward the floor. Every dollar of care that is denied and not successfully appealed is a dollar that moves from the claims side of the ledger to the retained revenue side. At United Health's enrollment scale, across 49 million members, a single percentage point of improvement in their medical loss ratio represents billions of dollars in retained premium. The algorithm is not a clinical tool being applied to a financial problem. It is a financial tool that was built to operate inside a clinical vocabulary. The AHIP lobbying timeline against the Safe Prior Authorization Act is instructive here, because it shows what the industry believes access to that retained revenue is worth defending. The Safe Prior Authorization Act, streamlining access to formulary and evidence-based prior authorization, was first introduced in 2018. It has been reintroduced in every congressional session since, with bipartisan co-sponsorship that reached more than 100 House co-sponsors by 2024. The bill's requirements are, by any clinical standard, modest. Prior authorization decisions must be made by clinicians qualified in the relevant specialty. Decisions must be returned within specific timeframes. And electronic prior authorization standards must be implemented across the industry. HIP's formal opposition letters to the bill's sponsors, filed with the Congressional Record, have consistently argued that the legislation would create administrative burdens harmful to patients through delayed approvals. The industry, whose prior authorization system denies more than 15 million requests annually, whose internal review process requires physicians to schedule peer-to-peer calls days in advance, and whose average denial to external appeal timeline runs weeks. That industry argued that requiring timely decisions from qualified clinicians would cause harm through delay. The bill was not brought to a floor vote. AHIP and member insurer lobbying expenditures have exceeded $150 million over the past decade, according to Open Secret's federal disclosure data. The math of what is being protected is visible in those two numbers together. Now let me show you the CMS insurer-level data, because it adds a dimension to this story that makes the clinical necessity justification for denial rates statistically untenable. CMS publishes prior authorization denial rates by individual Medicare Advantage plan as part of its audit and oversight framework. That data shows denial rates varying from below 3% at some plans to above 12% at others, a fourfold difference operating across the same federal benefit package, covering a population that is all Medicare eligible by definition and therefore bounded by the same broad clinical and demographic parameters. A fourfold difference in denial rates across plans covering the same benefit cannot be explained by clinical population variation alone. The plans with the highest denial rates are not concentrated in regions with uniquely complex patient populations. The variation correlates with plan ownership structure, enrollment growth targets, and profit margin performance, business variables, not clinical ones. The plan that denies 12% of prior authorization requests in a market where 80% of appealed denials are overturned by independent reviewers is generating incorrect denials at a rate that exceeds its correct ones among the cases that are challenged. It is doing so profitably because the appeal rate across its enrolled population stays below the error rate. That is not aggressive clinical management. That is a financial strategy operating inside a clinical regulatory framework funded by federal Medicare dollars and producing outcomes that CMS's own data shows are frequently wrong. The company discusses prior authorization on earnings calls as a component of their medical loss ratio management. Prior authorization is, in the company's own financial language, a medical loss ratio management tool. Read that phrase in full: medical loss ratio management. The word medical is in it. The function is financial. Your treatment is the loss they are managing. At the volume UnitedHealth processes, small improvements in prior authorization denial rates produce enormous financial outcomes. A 1 percentage point increase in denials that do not result in successful appeals across a population of 49 million insured members at an average per claim value well into the hundreds of dollars represents 9 figures of retained premium revenue. The AI does not need to be dramatically more accurate than a human reviewer. It needs to be dramatically faster and dramatically more consistent at applying the denial threshold at scale. It achieves both. Now let me show you the Cigna piece of this, because it makes the mechanism visible in its least mediated form. Before AI, when the same outcome was being produced by humans, moving fast enough to approximate what an algorithm would later make standard. In 2023, ProPublica published an investigation into Cigna's internal prior authorization review workflow. Reporters obtained internal documents showing that Cigna physicians were reviewing and denying prior authorization requests at an average speed of 1.2 seconds per case. Not per minute, per case. The physicians reviewing these files were not reading patient charts. They were moving through decision screens pre-populated by algorithmic triage. The physician's signature on the denial was legal cover for a determination that had already been made before they clicked. Cigna disputed the framing, but did not dispute the timing data. What the ProPublica investigation documented was not a rogue process carried out by bad actors. It was a designed workflow, built, tested, and scaled, because the appeal rate meant the financial risk of being wrong was smaller than the financial benefit of being fast. In 2024, the Senate Finance Committee formally requested documentation from both UnitedHealth and Cigna regarding their use of algorithmic and AI-assisted prior authorization processes. The committee's inquiry examined the relationship between AI implementation timelines and denial rate trajectories at both companies. The SAFE Prior Authorization Act, which would require that prior authorization decisions be made by qualified clinicians with actual knowledge of the specific patient's condition and history, has been introduced in Congress in multiple sessions. It has not passed. It has not received a floor vote. Let me show you the Medicare Advantage data, because this is where the design becomes most statistically undeniable, and because it affects more Americans than almost any other number in this story. Traditional Medicare, administered directly by the federal government, requires prior authorization for a narrow category of services. Medicare Advantage plans, which deliver traditional Medicare benefits through private insurers under contract with the federal government, and now cover more than 50% of all Medicare beneficiaries, impose prior authorization requirements across a far broader range of services. The insurers administering Medicare Advantage receive a fixed monthly payment from the federal government per enrolled member. Every approved claim reduces their retained margin on that fixed payment. Every denied claim that is not successfully appealed improves it. A 2023 analysis by the Kaiser Family Foundation, examining Medicare Advantage prior authorization denial outcomes, found that 82% of Medicare Advantage prior authorization denials taken to independent external review were overturned. 82%. More than 4 out of 5 cases where a patient or physician challenged the denial through the full appeals process were found by an independent reviewer with no financial relationship to the insurer to have been improperly denied. The error rate is not the scandal in isolation. The error rate, combined with the 11% appeal rate, is the financial machine. Because the 89% of denied patients who did not pursue the full appeals process did not receive a service that 4 out of 5 of their peers who did appeal were found to be entitled to. The system was wrong about those patients. The system was wrong at a rate that, if applied randomly, would constitute a catastrophic quality failure requiring immediate regulatory intervention. Applied in a consistent direction, always toward denial, always against the higher cost service, it is a revenue strategy operating inside a Medicare contract paid for by federal tax dollars. The population that does not appeal is not random. The elderly, the seriously ill, the financially pressured, the people managing active medical situations without the administrative support or legal fluency to navigate a multi-step bureaucratic process on a deadline. These are the populations the prior authorization AI encounters most frequently in post-acute and Medicare Advantage care. The 11% appeal rate is not distributed evenly across the covered population. It is lowest among the people least equipped to fight back. The algorithm was not deployed against that reality by accident. Here is what you are actually looking at the next time you see the word "denied" on a prior authorization letter. You are not looking at a medical judgment. You are not looking at a physician's review of your condition, your history, and your doctor's recommendation. You are looking at the output of a financial model that calculated the probability that you would accept this outcome, multiplied by the cost of the care being requested, divided by the appeal rate the company has historically observed for patients in your diagnostic category. That letter is a yield management document. It is the same class of decision that a hotel makes when it adjusts its room pricing at 2 in the morning, except the variable being optimized is not occupancy. It is the percentage of medical costs the company can avoid paying before the policyholder either gives up or pays out of pocket. Your premium was paid, your coverage was contracted, and the AI was deployed specifically to find the most efficient way to reduce what the company pays out against what you paid in. Every piece of the process is designed to support this outcome. The timeline is tight enough that most patients are dealing with an active health situation when the denial arrives. The appeals language is written in medical and billing code that is deliberately opaque to a non-specialist reader. The appeals deadline is typically 60 to 180 days, which sounds like enough time until you are managing a sick family member, a job, and a bill that may have already started collections. The insurance company's internal appeals reviewers work for the insurance company. The external review process exists, but requires knowing it exists, knowing you have the right to request it, and navigating a form. At every step, friction is the product. Every form that is not submitted is a denial that stands. Every deadline that passes is a claim that closes. Every patient who pays out of pocket rather than appeal is a policyholder who funded their care twice, once through premiums, once through direct payment, while the insurer kept both. The AI did not create this system. The AI industrialized it. Prior authorization denials were profitable before NH-Predict existed. What the algorithm added was scale. A human reviewer processing denial determinations might handle dozens of cases per day. An AI system processes thousands per second, which means the same financial logic operates simultaneously across a patient population large enough that even fractional improvements in denial rate produce 9-figure results on the income statement. There is one more layer to this that changes how you understand your insurance card entirely. The insurers call it the medical management ratio. It is a KPI. It is tracked quarterly. It is discussed on earnings calls. The word medical is in the phrase. The function is financial. Your care is the thing being managed, and the algorithm is the management tool. Your doctor spent years developing the clinical judgment that recommended your treatment. The algorithm spent a fraction of a second deciding it was not profitable to approve. If this is landing the way it should, here is what you can actually do with it. Because the system is built to win against people who do not know these 3 things exist. First, every denied prior authorization has a mandatory appeals pathway, and the external independent review is the one that matters. You have the right to an internal appeal and then to an independent external review by a reviewer who does not work for the insurer and has no financial relationship with the company. The external review overturn rate in Medicare Advantage, as the Kaiser Family Foundation data shows, exceeds 80%. File the appeal. File it in writing. File it before the deadline on the denial letter and request the external review by name. The form takes less than an hour. The insurer is required by law to comply with the external reviewer's decision. Second, your physician can request a peer-to-peer review, a direct conversation between your doctor and a physician at the insurance company. This inserts a human clinician into the process at the exact point where the algorithm currently operates alone. It is not guaranteed to change the outcome. But AMA data shows that peer-to-peer conversations with a qualified reviewer overturn denials at a rate significantly above the baseline. Most patients do not know this option exists. Most physicians do not proactively offer it because the hours they already spend on prior authorization leave little room for additional process steps. You can ask your doctor by name to request a peer-to-peer review. It is a standard option, and they can initiate it. Third, document everything the moment the denial arrives. The date, the denial code, the exact language used for the medical necessity determination, the name or identifier of the reviewer, if any is listed. If your case ever escalates to a state insurance commissioner complaint, a legal challenge, or a formal congressional inquiry, this paper trail is the foundation. The insurance company is tracking your behavior through the appeals process with the same precision they applied to the initial determination. You should track everything they send you with the same discipline. None of this makes the system fair. None of it returns the hours Dr. Reyes spent on hold scheduling a peer-to-peer call that upheld a wrong denial. None of it compensates the patients who did not appeal and received care on the algorithm's timeline instead of their physician's timeline, and experienced outcomes recorded nowhere in the company's prior authorization data. But it makes you harder to bet against. And that is the precise calculation the algorithm made about you the day your prior authorization was submitted. It estimated the probability that you would read the word denied and move on. The most direct response to a system engineered around your likely inaction is documented, structured, deadline-aware action. You are now harder to bet against than you were before you pressed play. Prior authorization is one mechanism in a healthcare billing architecture with several more underneath it, each designed around the same operating principle. Complexity is a revenue strategy, and the gap between what your coverage says it covers and what you can practically access is where the money lives. Every layer runs on friction. Every layer bets on your inertia. The AI denial machine is the most recently industrialized layer. The facility fee is the one that operates without requiring a denial at all. It activates the moment you walk through a door, before you have seen a physician or filed a single form. And the number it adds to your bill is not a mistake. It is a structural billing reclassification that most patients discover for the first time when the statement arrives. And that is what we are examining next.